Hi, everyone. Today I'm going to talk to you about some work my team and I are doing to address the need for a skilled alternative response workforce. And by alternative response workforce, I'm referring to mobile crisis team workforce as well as 911 dispatch community alternative response workforce. Um, I haven't been doing this work alone. I'm joined by a really talented team. My co-investigators on the project are Leah Pope and Michael Compton. We're also joined by doc student Kellen McNally and a team from the Center for Innovation in Community Safety, Tahir Duckett, Lucia Mock, and some uh, research assistants, Lucinda Q, Lisa Elliott, and Ashni Patel. The work that I'm going to talk about is also guided by a diverse advisory board comprised of people with lived experience, family members uh, that are working in peer services, youth crisis services, community responder programs, mental health providers, and law enforcement. The work is also funded by NAMI National. So first, I want to start by talking about the need to develop this crisis workforce. We know that as we have these efforts to expand access to mobile crisis teams and as more and more alternative response programs are being implemented across the country, we need people to do this work. But we're also doing this at a time where there's known behavioral health workforce shortages. In fact, a recent National Association of State Mental Health Program Directors survey found that 90% of state mental health directors report workforce shortages. And when we're talking specifically about mobile crisis team staffing, states are reporting the greatest shortages in social workers and other licensed clinicians and peer support specialists. And when agencies are able to hire people with the credentials, um, a licensed credential or master's level social worker or certified peer support specialist, those requirements don't always reflect the actual skills needed for this work, particularly for teams that respond to 911 calls. So it leaves it to agencies and programs to provide this training to their staff in-house. There's also no recognized training standard for mobile crisis or alternative community response work. In terms of community responder programs, this is really a new field. And what we've seen in this field is that staff qualifications really vary by program, but they tend to be less clinical. So while some teams may have licensed clinicians on them, many of the teams are really prioritizing other qualifications, oftentimes various types of lived experience, and then they bring people in that are a good fit and they provide that training in-house. Many of these programs have demonstrated that it is possible for non-degreed responders with appropriate training to safely and effectively provide crisis response. So the project that I've been working with my team on has a number of goals. And the first one is to really, instead of thinking about what existing professionals we can bring in to do this work, we wanted to take a step back and think about what do these responders need to be able to do? So the first goal of the project is to identify the core competencies needed for behavioral health crisis response, is particularly response that's independent of law enforcement most of the time. Um, the next thing we wanted to do was to identify what are the steps required to develop a recognized credential and a process for people to get the training they need and get that credential as a way of facilitating rapid entry into the workforce. So having a process that people that may have a high school or GED or some college that don't necessarily have a bachelor's or master's degree that can come in, get skills-focused training, and go through the credentialing process and get to work on these teams. The third goal is to identify the implementation and policy issues that need to be addressed in order to really move forward with this credential to help really expand this workforce. And then finally, our fourth goal is to develop and implement a training and credentialing process for what we're calling community behavioral health crisis responder role. So to address the first goal, which was to develop values, competencies, and skills for this workforce, we put together an advisory board. Again, I referred to in my acknowledgments, a really great group with a lot of different expertise and perspectives to help guide this work. We did a literature review looking at the literature on skills for people working within crisis services and other adjacent types of fields. We also included looking at the literature on the experiences of people who have used crisis services and their family members. We then did some key informant interviews with people with subject matter expertise related to running community responder programs, mobile crisis teams, law enforcement, EMS, peer crisis services, to really kind of get some information on one, what they thought the values, competencies, and skills would be, but then how that looks in terms of the work that they're doing. We then did focus groups with frontline staff working on community response teams and mobile crisis teams. We did focus groups with people with lived experience of mental illness and use of crisis services, as well as some focus groups with family members. And there, again, we asked them about what skills and competencies and values and characteristics they want crisis responders to have. We then went through some iterative rounds of feedback to come up with a final version of values and competencies and skills for this workforce. So I'm just going to share a few of the interview and focus group themes that helped kind of provide the basis for the values, competencies, and skills. First, in terms of values, many of the things that people talked about in terms of the characteristics of providers and the competencies and skills that they wanted reflected values. But when we asked them directly about values, the things that they directly said were that these responders need to have a commitment to anti-oppressive and anti-racist practice. They really need to be committed to person-centered care and collaborating with the people that they're serving. They talked about the value of unconditional positive regard, being trustworthy, and being very transparent. So really valuing those things that responders can bring to this work that would allow them to really form a connection with people, be trustworthy, and provide the support that people need. Another area of competencies and skills that people talked about really focused on the ability to engage and build a relationship and a trust quickly with the person that they're serving. And they talked a lot about just being able to form genuine and supportive connections. And there's a quote on the slide where one of our key informants talked about how this really being around alliance and being able to connect with people and let them feel truly seen, and that they can trust that you're there to support them. We also heard a lot about competencies and skills related to evidence-based interventions and knowledge domains. And here people talked about a lot of focus on motivational interviewing skills, being trauma-informed, as well as being really well versed in the philosophy and strategies around harm reduction. They talked a lot about cultural humility and being very sensitive to the communities and individuals that responders are supporting. Of course, they talked about responders need to be aware of mental health and substance use disorder presentations, and being able to recognize them, being able to do suicide and violence risk assessments and intervention. And they really talked about being able to do this in a way that didn't make people feel like they were being run through a checklist. Something that we heard from some of our lived experience groups is that sometimes people felt like if they started talking about having some suicidal ideation, that oftentimes the responder went into check checklist mode, and got very uncomfortable. So really the importance of having the knowledge, but also the ability to enter into those conversations with a person in a very respectful, calm manner. That we had folks talking about that responders need to be able to do level care assessments and do triaging, uh, having skills in basic medical, so being able to recognize basic medical issues that might be presenting as a behavioral health crisis, and knowing when to access EMS or other medical care. They need to be able to recognize signs of overdose and withdrawal and be able to administer Narcan if needed, and then some basic first aid skills, CPR and the like. Finally, they talked about, making sure that responders are well versed in good documentation practices, privacy, and legal issues around crisis response. Another thing is responders need to be very well versed in the community resources that they can connect people to. We asked specifically about skills related to maintaining safety in the community. And this really came out of earlier conversations we had had with providers that expressed some discomfort about going into the community without police accompanying them, as well as talking to some law enforcement folks that really felt it wasn't safe to send clinicians or responders out without law enforcement accompaniment. But when we did our key informant interviews and focus groups, we did talk to folks working on teams that regularly went out into the community without police. And we asked them to talk to us about kind of what are the skills that people need, and what do they work with their team on so they can do that safely. And what really rose to the top again was that approach and quality of the interaction. So a responder who's able to enter into that the space of responding and quickly develop an alliance, really being genuine and trustworthy can really help a person kind of down-regulate as well as feel safe in interacting with the responder. They also talked about the importance of de-escalation skills. They talked about specific training in nonviolent communication. Um, they shared some specific strategies for managing the physical environment, such as on the way to a call, if they're going to someone's home, asking that people secure pets and secure weapons. Also kind of looking at and getting any information they can in advance so they can make a safety assessment and come in prepared to manage safety. Situational awareness was also talked about a lot, making sure that responders kind of could keep track of situations and recognize when maybe an interaction is escalating and becoming unsafe, and then how to disengage and safely remove themselves from the situation. Some other operational strategies were shared in terms of making sure that when responders go out, that there's someone at base that knows where they're at and can do some check-ins to make sure that they're safe. And at the bottom of this slide is just a quote from one of our key informants that oversees several different teams that go out. And he really wanted to talk about, making sure teams recognize that they can give people space and so that the person that's maybe really agitated can down-regulate themselves, and not making them feel trapped or contained. So we also asked our key informants and focus group participants about what qualifications and what level of education responders should have. And the views really varied based on kind of the perspective that the participant brought to thinking about what crisis responders are expected to do. And so participants that really thought that responders' primary role was to go and assess people and link them to acute psychiatric and hospital-based care, really regarded master's degrees and licensure as necessary. And certainly, if that is the role of the team, in many states, it has to be a licensed clinician that makes that assessment. However, those who viewed the role in terms more of going out and providing support and stabilization in the community and connection to resources really prioritized lived experience and pretty broadly defined. So certainly could be certified peers, but it could just be someone who brings something to the work, like familiarity with the community and the population served. But really looking at that as being most important in term rather than formal education. We did have a few key informants that had master's degrees in clinical licensure that noted that the skills that they use as providers of crisis services were not the skills they learned in graduate schools. So they had to pick up those skills in training outside of their graduate work, which kind of goes back to thinking about requirements of graduate education may not be sufficient. It doesn't necessarily guarantee that people are prepared for the work. Additional training is needed. This is just a quote from another key informant that talked about how on his teams he has people with a range of educational backgrounds, and really feeling like it requires goodness of personality and willingness to learn rather than academic acumen. And this is someone who brought in people with different levels of education, and everybody went through the same training in terms of getting onboarded for his teams. So in order to finalize the values, competencies, and skills, we pulled together what we learned from the literature review, the information that had been provided from our advisory board, and then from the interviews and focus groups. And we put together an initial draft of the values, competencies, and skills, sent it to our advisory board and met with them to get feedback, made some revisions, redistributed it to our advisory board, as well as some additional external content experts. Got that feedback and then made it a final revision to come up with what we're using to guide the work going forward. So here is just, it's a pretty busy slide, but it's the values that we came up with for this work that really focus on the dignity of every person and being non-judgmental, the importance of developing trusting relationships with people that they're serving, collaboration with the person that's being served, respect for people's autonomy, inclusion of support systems, as well as assisting people in forging new connections if they need to build a support system, integrity, advocacy, being trauma-informed, and valuing lived experience as broadly defined. In terms of the competencies and skills, we kind of broke this down into 4 domains. The first one being around relationship building and communication, and really kind of focusing in on those skills of engagement and forming alliance and collaborating, also being culturally responsive as well. Also, self-awareness was in there and really making sure that responders kind of have a good sense of self and their ability to engage with folks that they're supporting in the community. The next domain is knowledge-based competencies and skills. And here, again, kind of at the top of the list are those knowledge-based domains that could really support people in building those relationships and being able to engage and form alliance with the people they're serving. It's motivational interviewing, trauma-informed care, harm reduction, and cultural humility. Additional knowledge-based competencies relate to having a basic knowledge of mental health and substance use disorder presentations, being able to do suicide and violence risk assessment and intervention, level of care, basic medical documentation and privacy, and community resources. Again, the safety-related competencies kind of go back and reflect for the themes that I talked about from the interviews, really looking at approach and quality, de-escalation, situational awareness. We have two other domains, and they're listed as other not because they're less important, but because they didn't quite fit cleanly into the other three domains. The first one is resource navigation and advocacy, and really making sure that responders are able to are familiar with what's available in the community, beyond just having a list of providers, but knowing what the different resources are, how to access them for people regardless of time of day or day of the week, and how to advocate to make sure people are able to get connected and access the resources they need. The final domain is self-care, making sure that responders recognize the importance of self-care for their own well-being, but also so that they can be effective responders to people in the community. So having a kind of coming up with our values, competencies, and skills, we're now working on developing what a training might look like that's really rooted in the values and supports the competencies and skills we identified. And so on this slide, we have basically training content topics that reflect those competencies and skills that I just talked about. And kind of thinking about how we can structure this into a training so that people really are able to develop the skills that they need to do this work. Also, one thing that really came through clearly in our interviews and focus groups that people talk to us a lot about is the importance of making sure that training isn't simply didactic training or sitting in a classroom and having information thrown at trainees, but also has significant components that are experiential. So making sure that people have the opportunities to practice skills in tabletop exercises and role play scenarios. Then they also have some supported field training as well, so that they can try on the skills, get feedback, get support, and really learn the skills that they need. So moving to starting to address our goals 2, 3, and 4, which are really to identify the steps that it takes to develop a credential, what are the implementation issues, and then move towards actually piloting this process. We did another round of key informant interviews. We did a review of other professional training programs, including EMT, community health worker, and peer support specialists. We've been looking at what states have developed specifically for mobile crisis team providers. And we're also looking at the training curricula for established community and alternative responder programs. So first, our look at what states are doing in terms of developing training for mobile crisis responders that are at the bachelor's or master's level. A number of states have actually developed some training that's required for people working in this space. Typically, they're about a total of 40 hours or less. And many of the states provide this training entirely online, either asynchronously or a combination of asynchronous and synchronously. There's a couple exceptions. I believe Utah's training includes some in-person content, and Michigan's does as well. But the ones that don't provide any in-person components of the training really have limited opportunity for skill development, which really leaves this to the agencies that are onboarding crisis workers to structure that additional training content and shadowing and kind of supported on-the-job training. Looking at the training academies for community responder programs, what we see is typically training academies that are about 6 weeks. The content varies based on the call types that the teams are designed to respond to, as well as the required qualifications of team members. Typically, there's observation and shadowing built directly into the training structure. And they may also include some additional training topics specific to the types of work that their teams will be doing. So after looking at the state mobile crisis trainings, some of the community responder training, as well as reviewing the credentialing requirements and training processes for EMTs, community health workers, and peer support specialists, we came up with a draft structure for a credential for what we're calling as community behavioral health crisis responder. And this would be for folks coming in with a high school diploma or GED. Um, we would bring them in. There'd be about 140 hours of didactic instruction, um, along with about 50 hours of skills lab. So 50 hours dedicated to actually really practicing the skills that they'll need on the job. About 50 additional hours doing some shadowing and community visits to become familiar with the roles as well as the other agencies and resources within the community. And once that part of the training is complete, workers would then go out and do 2,000 hours of supervised work experience before taking a credentialing exam. And that would get them a CBHCR basic credential. Um, One of the things when we talk to folks that people suggested we look at is that this is a process that could be structured as an apprenticeship program, which would then open up the opportunity to enter this workforce to a larger group of people, people that may not have the resources to take a bunch of time off of work to go through training. But with an apprenticeship program, they would enter the program and start getting paid from day one, and they would work and train as they're working towards the credential to become independent CBHCRs. This could also be considered similar to a CADC credential, where requirements could vary based on prior education. So this kind of draft structure is for people that don't have more than a high school or diploma or GED, but people with a bachelor's or master's degree may have different requirements to get the credential. We also anticipate additional levels of credentialing and maybe some specialization so that we can provide career ladders for people that decide to enter this work. And this would be similar to how EMTs, there's several levels of EMT credentialing moving into paramedic credentialing. And again, this could be a stackable credential as well. Many responder teams include people that have EMT certification and peer support specialist certification. So it could be stackable with other credentials for people that are working within this space. So thinking about this, the next step was really figuring out what we need to know in order to move forward and establish this into a credentialing process. So we did additional key informant interviews with folks with knowledge relevant to different areas that we thought would be relevant. And this is folks that have launched alternative response teams, people involved in workforce development, people with expertise in Medicaid and other payers, community colleges, apprenticeship experts, professional regulation and credentialing boards, and as well as allied professional regulations or organizations. So I'm going to just go over some of the themes that came out of those interviews. One of the themes was that people recognize there really is a need for national standards and training for this work. And having that would relieve the burden for small organizations so they don't have to recreate this for each time they onboard someone. Also, people thought there would be value in having standardized competency assessments as well as assessments for role suitability. Many of the people that we talked to did note that training and skills gaps in the existing responder workforce, that just because people have degrees, they don't necessarily have the skills coming on. So there's a lot of work that has to be done in the onboarding process. People also really pushed us to think about partnerships with different types of agencies and organizations. One being working with state certification boards to really start building the credibility of the new role. They also suggested we look at national credentialing boards as well, which would provide some reciprocity so people could move around and carry a credential with them. They pushed us to talk to community and technical colleges that have a lot of experience doing workforce development, that are very used to bringing people in and getting them prepared for specific workforce needs, and working with students that may not be kind of acclimated to the traditional academic setting. Um, that people suggested we talk to allied professional groups, one to support that training and scaling, but also to talk to those groups about concerns they would have about this new credentialed role and kind of what they see as needed in that space. And finally, they're talking to community-based organizations, because if you're going to create a credential, you need to have organizations that are willing to hire folks with the credential. So making sure that we talk to and look for, see if there's interest among organizations, but also to understand what their needs are as well in terms of what competencies responders should have. Um, People talked about training considerations, and really the importance of having some standardization of training, but also building in some flexibility for local contexts. Like our focus group participants and key informants, they talked about the importance of scenario-based training so people can practice their skills. And they particularly mentioned making sure that there's opportunities to practice in high-intensity situations. Um, there was comments around balancing lived experience with the importance of standard competencies earned through training and practical experience. And again, a number of our key informants talked to us about how the apprenticeship model could be a great strategy for engaging a diverse pool of trainees, engaging employers, and also capturing some Department of Labor funding for this process. Another theme that came out related to really elevating the prestige of this work, and so making sure that people recognize the importance of it. And one way of doing it is to look at getting first responder status for people working on mobile crisis teams and community response teams. We did talk to someone who said that when they got first responder status for their team members, they started getting kind of a different pool of applicants when they posted jobs, because I think it might attract some folks that simply posting a mobile crisis team member position may not get. They also talked about how that status could help improve pay and benefits for people in this role. There was a little bit of concern on how first responder status could potentially narrow the role in undesirable ways. And I think that concern was more around would that limit the ability of responders to do follow-up with folks. So just considerations to think about as moving forward in that direction. People also talked a lot about financial sustainability of these types of teams, and really thinking about how Medicaid reimbursement could be an important component of sustainability, but also how it could be a constraint in terms of scope, particularly for community responder teams that often will go to a broader range of calls for service that might not as cleanly fit into a Medicaid billing structure. Um, People also talked about trying to leverage parity regulations to make sure that both Medicaid and private insurers cover crisis services. We also had some conversations around political cycles and fiscal sustainability, which of course is an important one right now, given some of the changes at the federal level, although much of this work really sits at the state and community level. We were encouraged to really move forward of pushing and framing crisis response as an essential municipal service, and similar to police, fire, and EMS, really getting this as sort of that fourth branch of first response service. And then some folks also talk to us about the need to diversify funding and different ways of thinking about funding and funding mechanisms for these teams. So I want to touch on a little bit about then how we feel like this kind of fits into and leads to some potential policy levers for moving this work forward. Um, and one potential policy lever would be to push forward with introducing federal legislation to fund and support regional training and technical assistance centers that could help um, run training programs, establish credentialing in different states for this work. Money could potentially flow through HRSA or through the Department of Labor. Um, Given all that's going on at the federal level, well, I think it certainly makes sense to move forward at the federal level because and get things going. I think there's also a lot of room to do work at the state level as well. And I have some examples could be state legislation could support the development of an alternative crisis response credential. An example from Illinois is that there was state legislation that mandated and provide resources for developing a community health worker credential for the state of Illinois. So something similar could be done at the state level there. There could also be a state policy that establishes and funds training programs for this workforce. Um, I know there's some states that have also introduced legislation to provide first responder status to crisis responders and alternative responders. So that's another area at the state level that could be worked on. And finally, for crisis response services that might be funded via Medicaid or at least partially through Medicaid, states can do state plan amendments to the Medicaid program to make CBHCRs that are credentialed billable providers. So there's a number of different policy levers that could be kind of worked on in order to facilitate establishing this type of credential and making it a credential that could be sustainable and funded. So just briefly in terms of next steps for the work that we're doing is we're currently working with a state credentialing board, and just getting started to develop a credential. And along with that work, we're talking to a community college that's done some work in this space to think about it a site and for developing that initial training towards the credentialing in process. And of course, that takes funding. So we're talking to different funders about perhaps helping support the work going forward. And for anyone that's interested in more detail about how we develop the values, competencies, and skills, on this slide is just it's an article that was recently published in Frontiers Psychology. It's open access. So if you Google the title or part of the title and my name, you should get a link so that you can access it and download the entire article. I believe it was also, the link was shared in the AMSA newsletter as well. But that provides some additional information of some of the stuff that I went through pretty quickly in this presentation. And thank you everyone for listening.